Hello everyone. So next question is a 22 sorry one minute. A 22-year-old girl has been complaining of having itching rash on her face for 2 days. Okay. Then she associated this disease with application of cosmetic face cream. We got our answer. It seems objectively apparent reddening and edema of skin and region of cheeks, chin, and forehead. Find papulovesicular rash. Okay. So these signs, okay, like edema of the skin in the region of cheeks, chin, and forehead, fine papulovesicular rash, these are classical symptoms of allergy. Allergy, and from where the allergy came, the stimulus is cosmetic face cream. So it is allergic dermatitis. Okay. So we have symptoms of allergy and a trigger, that is your short allergic dermatitis. The next one, schizophrenic patient considered himself to be an outstanding scientist, a brilliant composer, and an unrivaled artist. He complains that family and friends are always jealous of him and want to poison him. Okay, so poison here it means want to harm. Okay, so anyone wants to harm himself. Okay, so these are psychiatric terms, and we need to know something about this a little bit. Okay, so heavy phrenic it means disorganized behavior. Behavior. Okay. Paratropic it is not a psychiatric term. Okay, it's totally parasitic. Parasitic. So it depends on another species or something to live. Okay. Maniac is elevated mode, super elevated mode. Okay, super elevated mode, or you can say extreme, right? So we left with paranoid and paranoid. Paranoid and paranoid. Both of them define the same, right? So first one is paranoid and second one is paranoid. Paranoid is an adjective and paranoid noun. So what is paranoid? Having false belief that other people are secretly attacking or want to harm him. So it is paranoid. It is paranoid. Okay, the adjective one. And paranoid is who is paranoid. Paranoid. So it is extreme fear of others. And this one is false belief. So there is a very little thin line between these two. One is noun and adjective. So here the patient is in fear that family and friends are trying to poison him or attack him. Okay, so this is paranoid, and the man is paranoid. Okay. A 42-year-old patient complains of back pain, dark urine, general weakness, dizziness that that occur after treating a cold with aspirin and ampicillin. Objectively, the patient is pale with a subiectoric sclera, heart rate 98, liver +2, spleen +3, in blood RBC 2.6, hemoglobin 60, chloride 0.9, WBC 9.4, basophil. Okay. Okay. So here we have a hematuria. Okay. Back pain. Then the patient is pale. He took NSAID and an antibiotic. Then we have RBC 2.6 very low, hemoglobin 60 low, chloride normally 0.85 to 1.1. Sorry, it's color index. Color index it's 0.85 to 1.1, so it's normal. And then we have WBC normal, basophil. These things are normal. ESR is high. Okay. And we have high bilirubin. So in millimole, it's 1.7 to 20 micromole. So 38, it's higher outside. Okay. So let's now see what diseases we have in options. Paroxysmal nocturnal hemoglobinuria. Here it is only hematuria or blood in urine only in night. This happens due to a deficiency of CD55 and CD57. Remember these things. Okay. So here nothing history of something like that, which is only in night. Agranulocytosis. We have WBC, basophil, eosinophil, all things are normal, so it's not agranulocytosis. Okay, cholelithiasis. Um, there is nothing toxic, no toxic syndrome. Okay, we have only what problem we have? We have only RBC is less than normal, as hemoglobin less than normal, ESR is higher, and bilirubin is higher. So these are not our answer. We have anemia, right? When RBC is low, hemoglobin low, we have anemia. We have anemia, and then what is in the option? Acute hemolytic anemia, and this hemolysis causes increase of bilirubin. So it matches. Okay. And why acute? Because it is drug induced due to aspirin. Okay. Aspirin is a blood thinner, we all know, and it can cause sepsis. But if you want to know something like the DD excess of anemia, we can discuss it. Actually, we can make a little chart. Okay, just so what we have. I am erasing this portion. Okay. So we can differentiate it by first one is size, then color index. In size we have macrocytic, then we can have normocytic, then we have microcytic. In color index, if color index is more than 1.1, it is hyper chromic. Then we have normochromic, and we have hypochromic. And if we join this, so macrocytic hyperchromic we get in vitamin B12 deficiency, vitamin B9 or folic acid deficiency. Microcytic hypochromic we get in iron deficiency. Okay. and normocytic normochromic we get in hemolysis, hemolytic anemia, hemolytic. Okay, so here we have color index is normal, so it is normocytic, and normochromic, sorry, and we don't have the size, so normochromic normocytic, it's hemolytic anemia. Okay. Then a hospital has admitted a 52-year-old patient with disseminated pulmonary tuberculosis, complaints of acute pain in the right half of chest that developed after going upstairs to third floor, cough, dyspnea, trace mark cyanosis. What kind of complications should suspect? Okay. So we don't need to think much about this question. Here we have disseminated pulmonary tuberculosis. Okay, and we have a history of some stress going upstairs to third floor, and this pulmonary tuberculosis, the dissemination can rupture. Okay, and we can have what if it rupture? We will have pneumothorax. The air will come into mediastinum. So it is spontaneous pneumothorax. No sign of cardiac failure, no sign of pulmonary failure, no sign of pleuritis, and no sign of acute myocardial infarction. You need to know these diseases. Okay, we'll discuss it later in any other video. Acute myocardial infarction is acute coronary, it comes under acute coronary syndrome. Okay, cardiac failure, we will have some specific signs like different sign for left ventricular failure, different sign for right ventricular failure. We have a pulmonary failure, there is no history like this. Okay, and no friction rub or something like that, so we don't have pleuritis too. So I think we'll discuss myocardial infarction in another question when I think we will get some. Okay. So what do we have next? A 38-year-old male patient has been taking alcohol for 3 years. Okay, 3 years. 3 days after a regular drinking period, he felt anxiety and fear. Anxiety and fear. It appeared to him that he was surrounded by spiders. So tactile hallucination and worms, and pursued by some condemnatory voices. So we have what we have. Say we have tactile and auditory hallucination. His behavior became aggressive. The patient demonstrated correct self-awareness but impairment of temporal and spatial orientation. Okay, so he have impairment of temporal and spatial orientation. Okay, so one thing we can exclude here, this is pathological intoxication, nothing. It is related to alcoholic. Okay, so we have delirium, alcoholism, alcoholic paranoia, alcoholic hallucination, alcoholic encephalopathy. So we need to know about these alcoholic syndromes. Okay, so first one is our delirium tremens. Okay, second one is alcoholic alcoholic hallucination. Okay, then we have alcoholic or round fits. And one more thing we have. No, we have two, I think. One is Wernicke's encephalopathy. And one is Korsakoff's psychosis. Okay. So delirium tremens. Okay. It occurs usually less than 72 hours onset. Okay. After withdrawal. Here we have the vital signs unstable. Okay. In alcoholic hallucination it is 8 to 12 hours onset. Okay. Here we have stable vital. Okay. Intact orientation. Okay. Alcoholic or rum pits, it is single or multiple general tonic clonic seizures. Okay. Wernicke encephalopathy, it caused by thiamine deficiency. You all know, right? And we have a beautiful triad of it: confusion, ophthalmoplegia, and ataxia. And the last one, Korsakoff psychosis, it seen after Wernicke's encephalopathy. The patient can have enteroretroamnesia, and classical sign is confabulation. Okay. So as we see, like 3 days after, so it's 72, and what happened? The impairment of temporal spatial orientation. So alcoholic hallucination can be our answer. There is no UTCS, there is no confusion, there is no ophthalmic ataxia, so it can be our answer. And if this can be our answer, this can be our answer also. So we left with, so alcoholic hallucination no, alcoholic paranoia no, alcoholic encephalopathy no, we left with delirium alcoholicum or delirium tremens. Okay. Next one. A 16-year-old patient who has a history of intense bleeding from minor cuts and sores. Need to have a root of the textbook expression. Examination revealed an increase in volume of knee joint, limitation of its mobility. As I said earlier, it is hemarthrosis. So hemarthrosis we have in hemophilia A. Okay. So the diagnosis here is hemophilia. Okay. Most probably A. There is no other changes. Blood analysis shows inclination to anemia. Okay. Before that intervention, it is required to prevent the bleeding from. Okay. So we can exclude some things. here? Yes, we can. So calcium chloride, it is used in hyperkalemia, antidote actually, hypocalcemia, hypocalcemia. So not our answer. Then we have dried blood plasma, or we can have fresh frozen plasma, like plasma thing. This thing, it is used in vitamin K deficiency, protein C S deficiency. We don't have something like this. We read earlier, right? What we have in hemophilia. Okay. If it is A, then factor 8. If it is B, then 9. Okay. Fibrinogen. What we will do with fibrinogen in this? Okay. Then we left with cryoprecipitate and ellipsonian aminocaptonic acid. Okay, these two are used in hemophilia, but this one it is as used as treatment. Okay, and cryoprecipitate we have fibrinogen, we have a factor 8, we have factor 9, we have one Willebrand factor. So we have all the components which we need in hemophilia. So this should be our answer, cryoprecipitate. Then next one, a 44-year-old patient complains about difficult urination, sensation of incomplete urinary bladder emptying. Sonography examination of the urinary bladder near the urethra entrance revealed an oval well-shaped hyperechogenic. Okay, so well-defined hyperechogenic formation 2 is 3. Okay, then large that was changing its position during the examination. Okay, so as the thing or the mass is changing its position, it can be a malignant tumor. Okay, or any of these. A polyp can be there, but here what we have well defined hyperechogenic formation. Okay, and sensation of incomplete urinary bladder emptying. So the thing is blocking, okay, the bladder mouth. Okay, so it is concrement or stone which is a calcium stone which is called concrement, right? Then a 35-year-old patient complains about pain and morning stiffness of hand and joint and temporomandibular joints that last over 30 minutes. She has this symptom for 2 years. Objectively, edema of the proximal interphalangeal digital joints. Okay, and limited motion of joints. What examination should be? So, what we have? We have here any arthritis, right? Morning pain and morning stiffness, and the age is 35. So young patient. So it is not osteoarthritis, morning stiffness, and it can be ankylosing, okay, or rheumatoid. So for that we need to do what? We need to do some tests. The first one should be a X-ray, okay, X-ray of the hands. These things are not needed in any arthritis. Complete blood count, it is a regular one, but it is not the diagnostic one, okay. So X-ray of hands is needed. Then a 69-year-old female patient complains of temperature rise up to 38, hematuria, ESR, hematuria, we have ESR, we have high temperature. Okay, antibacterial therapy turned out to be ineffective, so no infection is there. What might be that? The diagnosis. So in chronic glomerulonephritis, we won't have the temperature. Okay. Renal amyloidosis, polycystic renal disease. No symptoms about these things. No symptoms about polycystic renal disease and nothing about amyloidosis. It can be a cancer or urolithiasis, but as it says that it has hematuria, gross hematuria, and ESR is too high, and there is temperature rise. So we should go we should do DDX between renal cancer and urolithiasis. As I said before, some questions won't be have any explanation. Okay, so here just remember it. Like we have hematuria. Actually, if there is a bladder cancer, you have one specific term, that is painless hematuria. Painless hematuria. So if they give the term like this, it will be more clear towards cancer. Okay. And in urolithiasis, you will have pain. So here they haven't described anything about pain. So we'll go toward cancer because urolithiasis will give you some severe pains. Okay, so I think for this video it's enough. We'll discuss in our next video.